Sure. One of the things that we've learned is that in the real world, patients oftentimes want their medications to fit around their life, especially based on their symptoms. And we know that with a disease like atopic dermatitis, it can be waxing and waning with flares, periods of quiescence, maybe even periods of remission. And so the dream has always been a medication or a medication plan that can fit around where somebody is at. And so, with the way our clinical trials are typically designed, they're usually based on continuous treatment of a topical, continuous taking of an oral medication, continuous injections of a biologic therapy. But both a combination of real world data and even some of the unique designs on clinical trials have given us some insights in terms of how we might be able to change dosing from its traditional regimen. Well, it's a million or billion dollar question, but I would say that the patients that tend to respond the best to therapies, ones that have control of their signs and symptoms, are definitely the ones that are most amenable to some degree of dose flexibility. Some of our biologics allow us to go down to every 4 weeks of dosing or even every 8 weeks of dosing if our patients are doing pretty good. And so I feel like if your patient is getting to very high levels of improvement within several months of treatment, you can definitely think about that as an option. In the case of oral medications, this isn't something that's been excessively studied in a clinical trial format. This is more in the real world and anecdotal evidence. But for people that have more seasonal disease, maybe during certain parts of the year, or people that are doing pretty well, they might be able to potentially, in a slightly off label format, use their medication to fit their disease. So, for somebody that may not have bad symptoms of atopic dermatitis year round, they might really use their systemic therapy during that part of the year. For somebody that otherwise has achieved really high endpoints in terms of itch clearance as far as skin, they might actually end up using the medication a little less frequently. I've seen in my practice patients oftentimes do this and then tell you about it later. So I definitely have had patients that have moved down to not taking their medication every single day and still maintaining some degree of clearance. Now, there isn't hard data that I can point to say who exactly that patient is, how often this is going to work, but I do know that that is one of the benefits of an oral therapy for people out there. In the case of the biologics, again, I try to avoid too much starting and stopping here because that can be associated with really losing an effect and maybe not getting the same efficacy you had before. Try to get individuals on biologic therapy who need to be on year-round therapy. It's a good choice for them. And then once they're doing pretty well, we have data from an approved label fashion in the case of tralokinumab, lebrikizumab, and nemolizumab, where people can move down to every 4 weeks or every 8 weeks of dosing. In the case of dupilumab, on dosing is every 2 weeks, but we actually do have clinical trial data to suggest there might be people that could go down to every 4 or 8 weeks and still maintain their responses. Yeah, I think it's a lot easier to get somebody to really buy into a plan about a therapy or feel happy with their therapy if they're really able to allow it to fit their life. And so at the end of the day, I usually try to tell my patients, stick with me. Here's my plan. Give me a good year for us to get you in really good shape. And then we can talk a little bit, if you feel that you really want to, about how you might make this work with your life a little better. And I think at the end of the day, that's a really great way to get buy in from patients. And they feel like they're a big part of the plan in terms of really making sure that this medication works with what their goals are.